Hello, everybody, dear colleagues and dear friends. I'm very happy to be with you today for this reference course that organized by the Manos and all of this team. My subject for today is quite difficult because talking about current concept of stiff shoulder is difficult. So I would like to propose you a multicentric study we did in France that could be maybe the definitive answer. Okay. How to talk about current concept when you have more than 800 references for 10 years. Every year we have more than 100 references about stiff shoulder. We talk about adhesive capsulitis, frozen shoulder, stiffness shoulder. We have no prospective randomized study. We have no comparative study. We have no therapeutic consensus. In all cases, we have between 70 and 90% of good results. We have no clear protocol. So it's difficult to go forward. So because we are orthopedic surgeons, we are simple guy. We have just to go back to one symptom is that the shoulder is stiff. Stiff means a significant diminution of passive range of motion of more than 30%. So we decided a few years ago to do a prospective multicentric medical and surgical study, and we did it for more than 3 years following the patient. And then we compared 6 treatments. The first one was a conventional rehabilitation, rehabilitation under pain level. The second group was self-rehabilitation with pain limit, with no pain limit. The first one was exclusive self-rehabilitation over pain limit, patient alone. The second group was self-rehabilitation over pain limit with a physiotherapist. And the third group was combinated technique. I mean combinated because we talk about different things which are added as a treatment. I mean local regional anesthesia associated to conventional rehabilitation, capsular distension, and conventional rehabilitation, and endoscopic capsulotomy. So we have made all this treatment for 3 years with a very acute follow-up. So inclusion criteria was passive range of motion, decrease of more than 30 degrees, exclusion was bony lesion, fracture, arthrosis, and so on. So the revision document was quite complete. The surgeon was completed it at day 1, the first consultation, and then after 45 days, 3 months, 6 months, 1 year, and final revision at 3 years. We made goniometric measurement, range of motion, constant score, all etiology, evolution delay, pain, associated pathology. More interesting and more specific was the rehabilitation and physiotherapist document to follow. For each working exercise, we checked it every day for 6 weeks, every week for 3 months, about 4 general criteria for each exercise: day pain, night pain, functional limitation, psychic condition every day, and after for every exercise, what was the rate of difficulty, pain, and duration for each exercise. This was when the treatment was made by a physiotherapist. For self-rehabilitation, the patient himself was checking all his exercise on the same way every day. For every different self-rehabilitation exercise, check how it was done, difficulty, pain, duration, and for every day the criteria about pain, night pain, functional limitation, and psychic condition. So we have made a day-by-day analysis for 45 days, and after we have made a week-by-week analysis until 3 months, and 6 months, 1 year, and final revision. We have got 235 cases. So we have made the comparative study of each technique using all evaluation criteria. We have made the study of all correlation for each therapeutic technique in all criteria. We have made more than 25,000 correlation tests in this study. And at the end, we tried to analyze the therapeutic weight of each technique. So what were the results? The first result was that finally, after 3 years, the result was the same for each kind of technique. Well, this was the evolution of the constant score. So no statistical differences at revision. You can see in blue. In blue is conventional rehabilitation under pain limits. So still during the time the patient was under the hands of the therapeutes, we can say of the first 3 months, the progression of the constant score was quite okay, but immediately when the patient was left alone, it decreased, and then with difficulties until 3 years, it was again going up and up. So we can see the dependence of the patient according to therapy. And in red, you can see self-rehabilitation. They work hard for the first 6 weeks. After it decrease in self-rehabilitation, working every day, so it decreases in constant score. But because the patient is educated, it grows it again, and finally with a good results. Capsulotomy has a constant progression until 3 months, and it was quite stable. But this population, we will see that later, was quite selected. So this is the progression for 3 years. Specific point is external rotation. You can see that with the self-rehabilitation, patient cannot manage external rotation, and this limits the therapeutic results. So what about the failure? We can say that after 3 years, globally, we had 10% of failure. And we have made the follow-up more, and we have made the follow-up at 5 years for certain patients. If they are still stiff after 3 years, you can be sure that after 5 years, they are still stiff. So that's something else. That's not an orthopedic problem. It's a global problem of the patient. So first conclusion could be results are close to similar. Shoulder stiffness is an illness, and a follow-up of more than 1 year is needed, and patient education is one of the priority. What about pain? In conventional rehabilitation under pain limit, you can see that this is the more painful population. It's the same at the beginning, but after, because the patient is not educated, is afraid all of his life about pain limits on shoulders. So finally, after 3 years, you can see it's more painful. Self-rehabilitation is more painful at the beginning because the patient are working hard over pain limits, but finally it's one of the best population for pain-free. And capsulotomy is also a very good results about pain. So it was very funny to make this kind of correlation. We could demonstrate that with a conventional rehabilitation under pain limit, the level of day pain was correlated with night pain, functional limitation, psychic condition, duration of exercises, and negative impact on functional results and progression of motion. For self-rehabilitation over the pain limit, the level of day pain was correlated with the intensity of the exercises, normal, duration of exercise, functional improvement, psychic condition, and a very good positive impact on functional results. So this demonstrates that a patient with a rehabilitation under pain limit are more painful with bad psychic condition compared to patients with a self-rehabilitation over pain limit who are less painful and in better psychic condition. So the pain that somebody does to a patient afraid of what could happen is not acceptable and limits the quality of the clinical results. And the pain made by the patient himself is controlled, adapt, and help the patient to be secure. So we can say that manage pain limit with an active and motivated patient is one of the key for stiff shoulder. Question 2, what is the real place and efficiency of self-rehabilitation versus conventional rehabilitation? We could say that in green, exercise with a positive impact, in gray, no effect, and in red, bad effect of clinical results. So you can see all the list of conventional rehabilitation exercise at left. You can say that for stiff shoulder, the first 3 weeks, you only need balneotherapy, physiotherapy, all the other exercises have negative impact. At 6 weeks, it was a real demonstration of this. For self-rehabilitation, no negative impact because the patient adapts the exercises to himself and his pain, so we had no bad effect to the functional results. So we can say that if the self-rehabilitation over pain limit is assisted with a physiotherapist, the result is always better because it's a kind of positive coaching and makes the patient more secure. The third question was about capsulotomy. We had 45 cases. We can say that we had no difference at final revision with the technique and capsulotomy, but we had no complication and a very stable results at the end. So general conclusion could be, first one, we need a correct evaluation of passive motion. Second message, it's an illness. We have to follow the patient more than 1 year. Third message, don't be afraid of the pain. So what could be the place of self-rehabilitation? We have to take the best of the two worlds. For the first 3 weeks, patients with a physiotherapist are just trying to make self-rehabilitation over pain limit. After three weeks, we have to introduce conventional rehabilitation step by step. So the final message is to propose to the patient a progressive therapeutic procedure. Step 1 for 3 months, intensive self-rehabilitation, if possible controlled by an up-to-date physiotherapist. After 3 months, between 3 to 6, if positive evolution, just continue with self-rehabilitation. If not, if you are certain that the patient made the best, maybe you can propose something more aggressive like a distension. And most of the time, if you are not certain, just continue and observe. At 6 months, if you have a positive evolution, it's finished for a long time, it's okay, that's the end. If you have no positive evolution, if you are certain that the patient did the best, then it's a key tool to go to capsulotomy, and you will have a guarantee of a very good results and definitive results. If you are not certain, just leave the patient, and something else you cannot manage, so we have to stop with the patient. You cannot control all psychic condition, medical legal things, secondary benefit, so we have to stop. And first of all, don't go to capsulotomy, you will have a nightmare after that. So my final conclusion was to say we have to always follow this 3-step. The first day the patient comes for this kind of pathology, 3 months, 3 months, and 3 months. And because we have in Greece, I have to propose this Spartacus battle, which is like surgeon in front of the patient. We have not to be afraid of stiffness. We have just to share courage, energy, and confidence with our patients. Thank you.